joined us via purpose of gathering for today. Over to you, Abby Sarah.
Okay, so on behalf of GAN, we are all happy that this program is possible. The reason why we are gathered today is to have a CPD on hands-on experience in cardiopulmonary resuscitation. And we all know that it is necessary for us to build our capacity to know more about what is going on and to equip ourselves for any emergencies or in the course of our professional work, so that we'll be able to deliver as needed. So today our gathering here is just for the experts or the experience to be able to tell us what we can do best. Thank you.
Thank you very much, Abby Sarah. Okay, so like the name suggests, today's session is hands-on, so not much talking. Alright, so we're just going to introducing the resource personnel for today. He wanted a brief introduction, but I think on my investigation I found out more information about him. So our resource personnel for today's training has a wholesome background to this name. Coming all the way from Mount Florida, and he has had incredible feats since then. So he started AMPOSEC in 2005. And it is interesting to notice that after his secondary school education, he taught as a French teacher for 1 year. He went on to study general medicine at MTC in 2009, and then also studied and graduated UMass in 2015. He further specialized in emergency medicine at the Ghana College of Nurses and Midwives and graduated in 2020. He's currently a registered emergency nurse at the emergency department at Full Teaching Hospital. He's married, so that's sad for us. Good news for his wife. Okay, he's a lover and an astute student of the Word of God, which is very necessary in case and actually all of us are field of work. I mean, there's so much medicine coming. And if you cannot find him at his post at the hospital, you find him with the rest of his co-believers, sharing the gospel in the communities, as God instructed us to do. So aside from formal education, he has also participated in several training programs to sharpen his knowledge and skill sets for work. So he has experience and is here today with us as our resource personnel to train us on CPR. So let's welcome Mr. Wallace Doche. Bienvenue.
Thank you, MC. You shocked me by that gargantuan introduction. Hello. Those online, can you hear me, please? Right, thank you.
Okay.
So we'll have a good morning, everybody, those in person and those with us online. Yes, it's a hands-on experience that we're going to have. But we need to understand certain concepts about the CPR. So we'll run through a few things on slides, and then we go on with the hands-on practical. And I don't know how you are going to join us in the practical session. As we are doing it here, you'll be watching us. And observation is part of learning as well. So we'll start. I have a pre-test, and then that same pre-test will be used as a post-test after the presentation or after everything. So let's look at maybe the next one. So a pre-test. So those online, you can just leave your answers in the chat box. And then we take a screenshot of the answers they will be providing. If you have some papers, you can also take your paper and then put the answers down. It's very important. Knowledge before and then knowledge after. So basically, CPR has to do with cardiopulmonary resuscitation, and it is a component of basic life support as well as advanced cardiac life support. Basic life support entails a lot of things, the CPR, cardiopulmonary resuscitation. When somebody is choking, what you do? And when somebody has suddenly collapse, what you do as well. So all those things are part of the basic life support. So let's take this pre-test before we zoom into the real presentation. Pre-test 1. After cardiac arrest, how long does it take for biological test to occur? For biological test to occur to say that the person is dead finally. How long does it take? If somebody collapses right now, let's say we are here and one person goes down, becomes unresponsive. How long does it take for death to occur? Brainstem, the whole organs, the body, everything shuts down. Put down your distance. So is it 5 minutes, 8 minutes, 10 minutes, or 30 minutes? You know, if the heart is not pumping, it deprives the brain cells and other organs in the body blood supply. We know the blood carries oxygen, nutrients to, especially glucose to those cells. So after cardiac arrest, you know, brain cells cannot withstand hypoxemia. That is low oxygen level in the blood. So after how many minutes will the brain cells start to die? Is it 4 minutes, 6 minutes, 8 minutes, 15 minutes? Keep your answers, you are going to mark yourself when the presentation is ongoing. So what are the following? So what are the signs of cardiac arrest? In other words, the following are signs of cardiac arrest, except is it unconsciousness? Somebody becomes unresponsive? Is it apnea, that is absence of breathing? Is it absence of pulsation in the peripheral veins? That is radial veins. Your arm, the pulse, you know, we have the pulsating points on the body. Is it when your pupils are fixed and dilated? Now we can say that, okay, signs of. So what do you see on someone who is in cardiac arrest? If you are done with this one, you need to. How many minutes are you see the movie? All right. Cardiac arrest results in absence of tissue perfusion and aerobic metabolism, which leads to lactic acidosis in the body, and it moves on to affect other organs such as the kidney, and eventually you have anuria, which is absence of urine production. Is this statement true or false? Absence of tissue perfusion, there will be no blood supply to the tissues, to the organs in the body. And the anaerobic metabolism, they don't have oxygen to use it for metabolism. So, and this leads to lactic acidosis in the body that affects the body organs. Is this statement true or false? Then I must be a clinical health provider to successfully intervene in a patient with cardiac arrest. Is this also true or false? Do you necessarily have to be a health worker or be in the hospital before you will be able to intervene with someone with or in cardiac arrest? So, what is the correct sequence of effective CPR? If you are doing chest compression, how do you go? Do you look at the airway breathing circulation, or is it circulation airway breathing, or is it breathing airway circulation? Where do your priorities lie? Which one do you want to do first? And what is the rate of compression to respiration in an adult CPR? Is it 30:2, 30:4, or 15:2? When you are doing the chest compression, how many chest compressions do you do before you provide oxygen? I think the last one. So you are preparing for this meeting this morning when your neighbor came to call you that something is happening to the father in the room. She was calling him, but he was not answering. Then you quickly rushed to the scene. You went to the room. What will you do? Whatever you do, you just keep it to yourself. What will you do? You want to write down a few points so that they'll go. All right, so objectives for this session will be at the end of everything. We should be able to recognize and assess an unresponsive person. Then we should know the principles of basic life support. Then differentiate between cardiac arrest and heart attack. These are words that we use interchangeably. And understand the physiology of a person with cardiac arrest. Then administer chest compression and oxygen appropriately. So there is this image that I always project. This has been on Facebook, has been on the WhatsApp platforms. I don't know if any of you has come across it. And it has a story behind it. These two gentlemen work in an electricity company, not here in Ghana nor Africa, it's outside of our continent. And then while they were working, I should ask you what you see. So, what do you see? Who can tell us what is happening over there?
I think one person is, I don't use the word kissing. I think he's giving kind of like oxygen to the other person.
Okay. Yes, you are right. And the word is kissing. Actually, that is the nickname for this particular image. Kissing, life-saving, or kissing, kissing something. I also forget. So while they were working on the electric poles, the other guy at the top, the one with the head down, got electrocuted. Because when they're on the pole, they restrain themselves to the pole. So that when something happens and they fall, they will not land on the floor, they'll still be hanging. So that's what happened. So when he was electrocuted, he was hanging. The brother was with him on the pole. The two of them were working together. So he quickly got him and started giving him oxygen. Okay, so he was doing that, and a cameraman was passing by, saw them, and then took a shot. So he was doing that. Actually, he was lifeless on the pole. So he was giving oxygen, 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 oxygen. By the time the EMS team arrived, the guy was conscious up there, but was held down, went to the hospital, and his family was discharged. So what is the point here? The point is that you should give a little chance to anyone who you see unresponsive, no matter the environment. Just give a little chance to the person, do what you can do. Okay, you do what you can do for the person to do what you can do for the person to see the person will survive or not. That is it. All right, so introduction. Biological death occurs 8 minutes after cardiac arrest. So it means that if you meet someone unconscious on your way, or even at the workplace, banking hall, any social gathering, and somebody falls down all of a sudden, should the heart stop beating, the lungs stop functioning, this victim or casualty has only 8 minutes for any intervention to restore his life back. So after 8 minutes, the victim is gone, is dead. There's nothing you can do again. Okay, it's biologically dead. The brain stem is gone. Even if you are able to resuscitate him back to life, it will just be like a vegetable. Those are the time we use vegetable, it will just be in a vegetable state, be on ventilator, and relative will be spending money, but can never come back to life again unless it takes the miracle of God. So cardiac arrest is the sudden cessation of clinically detectable cardiac outputs. So when we say clinically detectable cardiac output, know when the heart is functioning. When the heart is functioning, it's pumping blood. So it gives us pulsation, which we can feel centrally or at the periphery. Central parts of the body where we can feel the heartbeat is the carotid artery, the groove over here. When you put your 2 fingers or 3 fingers here, you should be able to feel your heartbeat over there. That is the carotid artery. Or we have the femoral point here. That's in the groin. You can feel your arterial pressure over there. Okay, and then for the peripheral points, you can feel it at the radial, the radius, where we have the radial pulse. Okay, we have other areas at the ankle and the popliteal. We can feel over there. But if somebody collapses at that point, the body wants to spare the vital organs, the brain, the heart, the lungs, the liver, and the soul. Peripheral circulation will be cut off. So you cannot feel pulse at the periphery again. You can only feel the central pulse. But the central pulse is also absent. It means that this guy is not, the cardiac output is absent. Heart is not working again. So this will invariably result in respiratory arrest due to hypoxemia. Because blood is not going to the lungs, the lung tube will cease working. The lungs will not be working. So that's why in an attempt to bring the person back to life, we are working on the heart, and then we are working on the lungs. That is cardiopulmonary, heart and lung resuscitation. Are we okay? Next slide. So resuscitative measures should be initiated without delay once a cardiopulmonary arrest has been established. So look at how you establish this cardiopulmonary arrest. Because brain cells cannot withstand hypoxemia and hypoglycemia beyond 4 minutes. So after 4 minutes, when there is cardiac arrest, the blood is not going to the brain, oxygen is not going to the brain cells will begin to give up. After which, after 8 minutes, then the entire body goes off. When we are breathing normally like this, we are fine. Our oxygen reserve in the body is about 1.5 liters. Okay, so that is what the body uses for its compensatory mechanism when you have a problem, right? And in 3 to 5 minutes, this 1.5 liters of oxygen reserve you have in the body is exhausted when there is a problem. Okay, when you fall down right now, there's problem, the body will depend on this 1.5. It is consumed within 3 to 5 minutes. In the absence of maintained circulation, when your heart is no more working, the body will depend on this one. So after 3 to 5 minutes, that one will be exhausted. Let's go. So now, what is basic life support? So this includes both prompt recognition and immediate support of circulation and ventilation in cases of cardiac or respiratory arrest. Because if the heart that has stopped working, the lungs too has stopped working, so you want to bring them back to life. So the major objective is to provide oxygen to the heart and the brain, and to sustain tissue viability until definitive electrical or medical treatment. So, okay, medical treatment can restore spontaneous circulation. So for basic life support, we don't use any equipment. It is you and the casualty. Do the chest compression, then you give oxygen. Until definitive what? Electrical or medical treatment, that is when the ambulance team comes over. Or you are able to get means of transport to take this casualty to the hospital. So at the hospital, what happens is that we do advanced cardiac life support. Pre-hospital is basic life support, and in-hospital is advanced cardiac life support. Are we okay? Because we use equipment and medicine, but pre-hospital, there's no medicine, there's no equipment. So cardiac arrest versus heart attack, these are things that we use, and then, but the difference is that cardiac arrest has to do with unexpected loss of heart function. That is when the heart stops beating all of a sudden. Okay. Heart attack has to do with we call it MI. You are in the hospital setting, so you will hear it MI, like cardiac infarction. That is when the coronary artery that supplies blood to parts of the heart or muscles, heart muscles, is blocked by either a blood clot or is constricted. But when it is blocked, the blood will no longer be serving that muscle, and that muscle will be deprived of oxygen and then nutrients. So when it happens like that, the victim or the patient will begin to have chest pain. It starts with chest pain, which radiates to the shoulder and it goes to the jaw. The person will tell you that at the tip of the scapula to the jaw and then to the left arm. Those are classical signs of myocardial infarction. And then shortness of breath will set in. Then you see this person start sweating. By the time you realize the person falls on the floor, if you don't intervene quickly. So that is heart attack. It has to do with lack of oxygen supply to the heart muscle due to the blockage. But cardiac arrest have to do with electrical connectivity of the heart, electrical problem in the heart. So this leads to unconsciousness and no pulse. The heart will stop working. This also requires immediate attention, CPR and defibrillation to restore the heart rhythm. Without immediate intervention, this can lead to death within minutes. So for cardiac arrest, if you put the client or the patient on defibrillator, it will give you the abnormal rhythm of the heart. Okay, so the abnormal rhythm of the heart that you can shock, we call it ventricular fibrillation or ventricular tachycardia or pulseless ventricular tachycardia. These are the two shockable rhythms. Okay. So principles of successful CPR. We need to recognize the event as early as possible. And then timely intervention. When you recognize it, you start intervening immediately. You don't run away from the victim who is on the floor and be calling for help. You have to start something for help to come and meet you. And then who has to do this? A skilled or trained personnel. If you are not trained, you cannot do it. But if you are trained, you will be able to master courage and then approach this casualty or victim. So what are the cardinal signs for diagnosing cardiac arrest? Number one, unconsciousness. Somebody is unresponsive. You should suspect that this person will have cardiac arrest. Absence of pulsation in the major arteries. As we mentioned, the carotid artery or the femoral artery, the femoral pulse. The absence of breathing. The patient is not breathing. How do you know this? You observe for rise and fall of the chest. When we breathe, our chest rises and falls. But when we stop breathing, our chest doesn't go through that mechanical movement again. Then the next thing you can also observe is fixed and dilated eye. When you introduce torchlight or lights, the pupils do not react to light, they do not constrict because they are fully dilated and sometimes they are blown out. So consequences of cardiopulmonary arrest, when somebody arrests or heart stop functioning, there's global ischemia resulting in dilated pupils because the blood vessels are no more receiving blood. Blood is no more flowing through them. They become ischemic, they become constricted, and this leads to the dilated pupils. Then in the absence of breathing, because their lungs are no more receiving blood for their function, and the one goes unconscious. And then eventually there is brain death. So this absence of tissue perfusion can lead to anaerobic metabolism, which will eventually lead to lactic acidosis in the body. And then when the lungs are no more also receiving blood to perform their function, then the one will not be able to what? Will not be able to urinate again. Eventually there's kidney failure, absence of urine production. So a lot of things are happening at the same time. So what are the procedures for basic life support? The main objective is to pump blood into the brain. So circulatory support. And then you maintain the airway because the one is not breathing. So you're going to breathe for the victim. You're going to provide oxygen for the victim. So before the oxygen will go to the airway must be taken, must be clear. There shouldn't be anything that will block your air that you're providing to this victim. Then breathing and without the use of equipment other than protective devices. So we don't have any equipment. Now we are discouraging or American Heart Association is discouraging mouth-to-mouth due to this COVID and other infectious diseases. So but it's your relative, God forbid, any close person to you who arrests, you can go mouth to mouth. Then advanced life support, as I mentioned, is the use of equipment and materials to maintain the airway, respiratory, circulatory support in cardiac arrest. Right. So the sequence, CPR is as easy as that. CPR is as easy as that. Okay. So if somebody is in cardiac arrest, you don't do A, B, C, D, E approach. You do the reverse CAD because we want circulation, airway breathing, circulation, airway breathing. So compression, we will look at it in the subsequent slides. So CPR chain of survival. So for the victim to survive what you are doing, you need to follow a chain. Okay, it links. You need to follow that. So you need, when you recognize that somebody is in cardiac arrest, what do you do? After confirming that truly this person is in cardiac arrest, you need to activate emergency response. Okay, it means that you need to call for help. And all over is the ambulance or the emergency medical technician that are called. But in our part of the world here, the knowledge is not so much large like that. So in the public domain, so if somebody arrests, they just push the person into a taxi and they are on the way to the hospital. So they rather help in killing the victim. Something happened at the stadium. I hope you have heard it. Some time ago, Go Stadium, a few months ago, when the police officer, who is also a referee, watching the game, suddenly collapsed. And understood the Red Cross, they went for him. And while they were passing his colleagues, officers saw them, realized that, oh, it's one of them. And they took the victim from the Red Cross personnel and took him in the pickup in a sitting position. By the time they reached the hospital, he's gone. If they had given chance to the Red Cross personnel to do their work, probably this guy would have been the one missed by now. So it's gone. So when you recognize that somebody is in arrest, activate emergency response, call for help immediately. Shout if there's nobody around. If you have ambulance control room or the EMT's contacts on your phone, call them and put their phone on loudspeaker and start chest compression. Or if there's anybody around, contact the person. You give your phone to the person to call the ambulance number on your phone. Okay, call them and then tell them the location, tell them that this is what is happening, so they should quickly come to the rescue of the victim. So perform early CPR, start CPR as early as possible. And then when the ambulance team comes, they will bring a defibrillator. They have, this is defibrillator, they have it in the ambulance. They will bring it and then fix it on the patient or the victim's chest. Elsewhere, understand the AED. This is the AED, automated external defibrillator. Okay, it's automated. We have the manual one, which also has the AED components that we use in the hospitals, our defibrillator. That's why the defibrillators are all over the places like this. Or there should be a defibrillator on the wall somewhere because the events, meetings, gatherings are being here, people can't pay for functions. Anything I'm talking about, we just pick it, fix it. If it is an electrical problem, the AED will detect it and give a shock. The person will come back to life. So then one thing comes, apply the defibrillator, and then put the victim into the ambulance and quickly call the facility where they are sending this victim. When the victim gets to the emergency, they go on with advanced life support or advanced cardiac life support, ACLS. Then if the victim survives it, post-cardiac arrest care is very important. There are certain things, IV fluids, medication, continuous monitoring, or you send the victim to the ICU for ventilation or ventilatory support. And then recovery. The one may recover with some severe or moderate disabilities. Then there should be counseling. Okay, and if the problem, what leads to the cardiac arrest is identified, then we may also ask the patient to come and see you, dietitians, for dietary management of certain aspect of his diet or her diet. So these are the chains of survival. Okay, let's go. So the action plan, how do you approach the CPR? So if you see somebody lying down, like we saw in the pre-test, the scene, that you're called that the man is unresponsive in the room, and then you rush there. What do you do as a rescuer? You have to make sure that the victim, the one lying on the floor, anybody around is safe. Make sure the environment, the ground where the person is safe. or maybe something happened, a snake has bitten the one and is in the bush, maybe a path on your path to it. Then the snake is around. You also quickly rush there without observing. The snake will bite you too. So check the victim for a response. How do you do that? So you gently shake the shoulders of the victim on the floor. Okay? Hello? Hello, can you hear me? Is everything all right? So whatever you can do to elicit response from the victim, you do it. Okay? And then if he responds, meaning there's cardiac output, the lungs are working, so you leave him in a position in which you find it, provided there's no further danger in the environment. So try to find out what went wrong, what happened to him. Possibly maybe he's diabetic and he's in hypoglycemia. So at that moment that you have across him, you could get him a Fanta. If he tells you that, oh, I am hyperglycemic, or I am diabetic, and I didn't take, or I took my medicine, I didn't eat, whatever the person tells you, you will go to intervene. Then you find out if you can call someone, if he has his phone, you call a relative, but you can send him to the hospital, relative that you have sent him to the hospital, you should come to the hospital and then meet him. Then you are done with the responsive casualty that you have found on the ground. But if the one does not respond after calling him, are you all right? Is everything okay? Hello, hello, sir. Are you okay? Are you okay? There's no response. Now, there's no response, it means it's unresponsive. Do you have to start CPR? No. Find out if the heart is working and if the lungs are working. That is, the victim is breathing and if there's cardiac output. So we are going to assess the victim within 10 seconds, right? So you are going to, open the mouth. So we call it a head tilt chainlet. Okay. You position your hand here, then you this way, you open the mouth, so that if it's breathing, at least it will first, the air coming out can hit your cheek, you feel it, and then you observe the rise and fall of the chest while checking the carotid pulse at the same time. So you quickly observe. This will happen within 10 seconds. Okay, I confirm that there is no pulse. There's no rise and fall of the chest. If you have your phone, you call the ambulance, you dial the number, put it on loudspeaker. Or if there's somebody around, hello, madam, can you call the ambulance? Tell them that somebody is on the floor here, we are trying to bring back to life. Then you start CPR. You do CPR, then the compressions, then head tilt, change it, open the way you pinch the nose, and you blow air. You load and then offload. Okay? You take in deep in breathing, and then you give it to the patient. 1, 2, go back, CPR. You will be doing that until the rest comes. Until help comes. Okay? So we will do the demonstration. Right. So that's the contact number for the VR control room ambulance service. We are supposed to have this number on our phone, write it, paste it on our door everywhere. Every member of your house should know this number, the back of our doors. Call this number in case of emergency. You may not be in the house. Your children are in the house. Family members are around. There could be anything. There could be fire. There could be anything. So at the back of our doors, we're supposed to have the emergency contact, police, fire, and then the emergency service. Okay, I didn't mention AED because we don't have AED in our part of the world here. When the ambulance people, to open the AV. So do 30 compressions with 2 rescue breaths. So how do you start the chest compression? Okay. So normally it's recommended that the point of compressions is the middle line, the midline over the lower half zone of the sternum. So I think when you put your hand in the armpit of the victim, then you slide it over the breast. You are there. There's which at the center of the chest. Some people, when on the watch, you see them putting it on the heart here. You break the ribs as fast as possible. But it's at the center, not on the heart. Lower half zone of the sternum, which is the center here. Right, let's go. So you put your dominant hand over there. You put the second one over it. You interlock your fingers. Then the heel of your dominant hand is at the center. Okay. And then you straighten your elbow joints. There are some people who cannot their elbow joints. No matter how they do it, it is like this. On the victim. And the victim, okay, it's already on the hard surface background. You are not in the hospital setting. All right, like this image that you are seeing, you interlock your fingers, your palm does not lie on the victim's chest or the patient's chest. It's a bit elevated. Just the heel is on the chest. Okay, let's go. And then you compress. You push hard and fast. It should be at least 2 inches or 4 to 5 cm deep, the depth of the compression. Now you allow for complete chest recoil. Why do you have to allow for complete chest recoil? Because you are compressing the heart. So if you don't allow for complete chest recoil, the heart chambers will not be filled for ejection. So when you press, you eject. When you allow for complete chest recoil, you allow the chambers to be refilled for you to push back again. And then minimal interruptions. There shouldn't be any interruption because we don't have time. We have to revive this victim as early as possible. So there's no time to waste at all. So that's it. That's an EMS personnel doing the CPR. Let's go. So after 30 compressions, open the airway again using neck tilts and chin lifts. Pinch the soft part of the nose closed using the index finger and thumb, and then your hand on the forehead. Allow the mouth to open to maintain chin lifts, and then you blow air into the mouth, to the mouth. Load and offload. That's the head tilt, chin lift. When you do that, it's like you are in a sniffing position. Like you're passing the back of somebody's kitchen, the person is preparing stew. And say, what a nice aroma. So that position that you do to sniff the aroma of the stew, you open the airway. So that is what you want to have over there. And then if it is after pain that somebody becomes unresponsive, the one doesn't have a pulse, it's not breathing, and you have the strength to intervene. We don't do head tilts and chin lifts when you see someone with facial injuries because of the C-spine. You're suspecting C-spine injuries. You don't do head tilt, chin lifts. What you do is jaw casts. Okay, just hold. So you hold the jaw like this. Okay. So you hold the patient's head like this, and then you open the mouth. You don't do this one. Because if you do, and there's injury to the spine, you are going to worsen the injury to the C-spine, the cervical spine. Okay. So that's mouth-to-mouth breathing, which is being discouraged. we are now doing mouth to mask. So if you are trained in BLS, everywhere you go, you are supposed to have this mask with you if you want to save life. So if something happens, we just put it over the mouth of the victim, and then we blow the air through it. As we can see over there, mouth to mask breathing. Right, this one is applying it. Good. So if you do the chest compression, you give your mouth to mask or mouth to mouth, and the victims comes back to life. That is return of spontaneous circulation. If the heart picks up and then the breathing is back, you turn the victim to a recovery position, as we can see over there. The recovery position allows for airway to be open, and it improves oxygenation because the one can now breathe while you wait for means of transport to the hospital. The chest compression should be 100 to 120 compressions in a minute. So you see, it should be fast, but it should be rhythmic. Good. It should be regular. But there is a song, something beats that they use in CPR. So if you have that music, especially in the hospital, playing it when you doing it while doing the exam. So what are the outcomes of a CPR? You could have a good recovery, patients will come back to life, thank you, then go back to the family, or moderate disability, there could be impairment or severe disability. Patient may not be the same again. Persistent vegetative state where the one will just be lying down, dependent on everybody, cannot do anything for him or herself. No daily life activities will be done. Then brainstem death, and then biological death. Brainstem, there's an assessment you do, you introduce cotton to the eyes or the low movement, you pour water into the ear to see if the eyes will move. I think 5 steps in determining the brainstem death. And then biological death, you cannot say that the whole body of this victim is dead. Because if somebody is lying unresponsive, it doesn't mean that the one is dead. If you intervene, you bring the person back to life. Yes. So many factors influence the ethical reasoning in resuscitation. How long do you have to continue compressing this chest, especially when the one gets to the hospital? How long do you have to stop? For us at emergency, until we are tired. So we'll be doing it. We are in queue. The compressors are queue. We do it to until somebody takes over, one person takes over until you are all tired, or you review the person's record. If it's an old client with us, we review the report, or after time, all the H's and the T's. Those are the possible causes of cardiac arrest, the H's and T's. After running through them, the basic ones that can be managed, one of the H's is the person had hypoxic, is the one hypoglycemic or hyperglycemic, hypokalemia, hyperkalemia. We try to intervene for all of them. And then the T aspect, is it toxins, like sepsis? Is it tension pneumothorax, like trauma cases that come to the ED? So we review all of them. Is it cardiac tamponage? We get pressure on the heart that the heart cannot contract, then we intervene. After doing all that and we don't have any positive results, then we call it off. So overall, 20% of the survivors of cardiac arrest leave the hospital alive. That is when they are picked up early at the pre-hospital site, and then interventions are applied appropriately, then the vehicle ambulance, and then they are brought to the hospital. Then we take up with advanced cardiac life support. At least 20% of them, according to research, go home back to their families. So this one is back mask ventilation, go down. You have seen that part before, back valve, back mask ventilation, back valve BMV ventilation, and go back, that we are calling it. So if the one comes to the hospital, then we don't do mouth to mouth again because we are going to use equipment. So somebody will do the it, and then another person will be doing the backing, just compression, 30 compressions, then back 2 times. That's so the second topic, so can you tap on the on internet? Please select the last one. Let's see how the heart behaves like 3D look inside the body when we are doing the chest compression. If your Chrome is open, and copy into the Chrome. Control and click on the link.
Opera, then should be open by now. Like that, let me put it in.
So we are trying to watch the 3D look inside the body, how the heart or the circulatory system behaves when we are doing the chest compression.
YouTube. I'm going to share it.
Which we are there. All right. Is it playing?
It's loading.
Okay. So many things are So that's the 3D look inside the heart. It's not compressing. Good. Well, so the guy is back to compress. Then
Okay.
all right, so the guy is compressing. I think there's a voice. You can hear, right? So if you are doing a compression well, that is what happens. As you can see on the video, good compression, blood flow to the brain, very good. you allow the chest to recoil. But if you are not doing the compression well, you see what is happening overhand. So this is the good one. Blood is going all over. But if you are not doing it well, you are not pushing hard, the blood cannot go to the brain, and the heart too cannot be filled up for subsequent injection into the brain. Is it over? So like this one, can you see the blood is not getting to the brain? Like this one, you are not allowing for full recoil of the chest. So that is what happens in the circulatory system. And when you are doing it too fast, this is what happens. The blood is not getting into the heart for refilling, and it's not even getting to the brain. So you sweat during the compression and you achieve nothing. And then when it's like this, so this is the good one. Good chest compression, push hard and fast. Pa, 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 pa. Let's see the second video. That's an incident happened at work, and then someone collapses. Yeah, click down the video. So there's an app called the Super CPR. Super CPR. This one we are doing advanced cardiac life support. Easy to time because you need to time the process, the time you give medication, and then the time you check the pulse. Medication is given after every 2 minutes. You give adrenaline after every 2 minutes during the chest compression. And then after every 3 to 4 minutes, you do pulse and breathing, because this victim will be on monitor. So let's watch what is going to happen there. So this guy came complaining of chest pain, and before the colleague realized he's on the floor, unresponsive. So he's asking that they call the 911, get the aid. He's going to check for breathing, watching the chest for rise and fall. It's absent, so he slides the arm. Have you seen it? So he starts the chest compression. 30 to 2. Push hard and fast. This kind of beat. So the other lady has gone to pick the AED. She's coming. She's going to apply the AED, the defibrillator, on the chest of the patient. Can you see that it's rhythmical? Can you see? Good. It's synchronized with this beat here. So you don't stop the chest compression until it is not supposed to stop the compression. The one with the defibrillator should find her way to apply the pads on the chest, because we don't want interruption. If interruption, it should be minimal. And the interruption should not be more than 10 seconds. Everything you are doing in saving life, if you are going to interrupt any process, it shouldn't be more than 10 seconds. So be sure no one is touching the patient when the defibrillator is applied. Now this is automatic, so it will be giving you prompts, instructions to carry. We're going to clear, nobody should touch. She has shocked the patient. If you shock the patient will check either using the AED or the manual defibrillator you have on the wall. Those things that we see on movies when you shock the patient, then the patient will jump from the bed, go and hit the ceiling and come back. It's like that in a real life situation, in a clinical situation, nothing happens. So it has the mask in the defibrillator. I think the defibrillator has asked them to hold on. So this time, no shock advised. Check breathing. So it means that at the initial stage where shock was delivered, it was a shockable rhythm that was identified. It could be either pulseless, ventricular tachycardia, where the ventricles are just pumping too fast, but there's no pulse, or ventricular fibrillation, where the heart is just quivering, it's just, I don't know how to describe it. The heart is just twitching. The heart muscles are just twitching, but they are not pumping. Yes, so these two, the defibrillator will shock. The first one, which is ventricular fibrillation, that the defibrillator shocks, it delivers shock. Okay, but when we have pulseless ventricular tachycardia, where patient is symptomatic, I mean, patient is having difficulty breathing and that, others that you want to shock. Now, if you want to shock, you need to give, if the patient is conscious, you need to give medication to the patient. Then what we do is cardioversion. You cardiovert. Meaning the ventricles are beating, but just that they are beating too fast. So you want to bring them back to regular beating or beats or regular rhythm of the heart. So that is what we do to bring them back to life. So we've watched the video. We are going to go down with this. Let me see what is on the next slide. Okay, conclusion. So continual beating or contracting of the heart is very important. Early detection of the incident is key. Then timely intervention is also very important. Transport to the hospital. Not all of them will survive. So it is good that we give chance to anybody at all who goes unresponsive or unconscious. Doing something is better than doing nothing at all. It's better than doing nothing at all. I think that is the last thing of my slides. Thank you for your attention. If you have any questions, you can ask. While we all come and try our hands on this guy here. So this is the defibrillator. So let's go. So this one, okay, the instructions are there. If the patient is unconscious and is not breathing, press the green. This one. To on the machine. So when you come, the first thing you do is to connect patient to the defibrillator. Okay. Then you connect the parts. How do you connect the parts? The RA is to the right, just below the clavicle. Just below the clavicle, and then this one left is at the apex of the heart. So this is how. So this is how you fix it.
Get closer.
This is how you fix it on the patient. Okay. So if I should remove my shirt now and apply it and I on the machine, it will go through the process. And if I have issue or did that, it will ask that you should shock me. Right. So then you on it. Check the parts. Check the parts. It's asking you to check the parts. It means that you have not removed the covering in the parts. This one, you need to remove them. Okay. This is my first time. I'm going to remove them. I don't normally remove them. So check the parts. This is right. And this is the sternum. Okay. Because this is not a live body, it will not detect it. It will not detect it. But if it detects it, it will ask you to stop CPR. So immediately the victim is, the parts are applied, you stop the CPR. Why do you stop the CPR? You stop the CPR for the defibrillator to analyze the heart, to see what is happening to the heart. If it is electrical problem. If it is electrical problem, it will analyze which one it is and ask you to shock. Okay? And then when it asks you to shock, you press the shock button here. You press the shock button here. So this one is not a live or a body, so we can't go through the process. So after shocking, it will ask you to start CPR. This time when you are doing the CPR, the machine will be counting for you. It will be counting 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, up to 30. Then you breathe. You'll be doing that, and if it realizes that there is something happening to the heart again, it will ask you to stop. So it's automated. After every 2 minutes, after every 3 to 4 minutes, it will do rating check. It will ask you to stop and then analyze the heart. And then if it is shockable, it will ask you to shock. If it is not shockable, no shock advice. If no shock advice, is the heart back now? If it's back, is it regular? Do you now have a sinus rhythm? The normal one is a sinus rhythm. The QRS complex, everything is fine. Then patient, you check, there's pulse now, patient is breathing. Okay, put patient into a recovery position while you wait for means of transport to the hospital. Are we okay? So that's how you apply the parts on the chest of the victim. Okay, so I'm going to demonstrate. Let's say this guy is unresponsive, right? It's a part, so ideally it's disposable. Or you use it on a patient, you dispose it, go and pick another one, but we don't have it. So there's one that we are using on our manual defibrillator. And we keep it. When we use it, we keep it for the next victim. Because if you are using the manual defibrillator, you should be able to identify the rhythm on the monitor, on the defibrillator. Those spikes that pass, you should be able to identify which one is the ventricular fibrillation and then which one is the ventricular or pulseless ventricular tachycardia. So how you can intervene. So let's say just on my normal movement in the area, then I see that somebody is on the floor. Okay, so what is the approach? I get there, I look at the environment. Is the environment safe? Or are there stones around or some woods around that if I want to save him, can injure me or injure the victim? Okay, so if I see that, okay, I can quickly move, right? I can move the victim. I can move the victim if it's somebody I can carry. Other than that, I have to call for help. Okay, Juliet,
Sylvia.
pardon me.
Sylvia.
Sylvia, this is Sylvia, can you help me? It's like this man is not fine. but the place is not found. Okay. So you can move him to a separate area where the stores everything are off. And you should know that if it is the public domain, people will come around. Right. People will come around, but you as a trained person, you should be able to control crowd. Or you should be able to delegate people to control the crowd. Right. So I just saw this that the environment, the area is safe. There's nothing there to injure him or me. So I go. Hello, sir. Hello, sir. Hello. Are you all right? Is everything okay? No response. I have to confirm whether response or breathing. Right. So in 10 seconds, I have to check for pulse and then breathing. What did we say? You open the mouth. As you watch for what? Chest breathing. Chest rise and fall of the chest, because when somebody is down there, the person will be breathing, will be abdominal breathing. The chest movements will not be as for we the normal people walking about. But if the chest is not rising and falling, it is not rising and falling. Right. So 10 minutes, no movement of the chest or no up and down movement of the chest. What do I do? I have to start CPR. But before you start the CPR, you have to call for help. If you don't call for help, you'll be there, you'll be doing it till any time. You'll be tired, you go. So you call for help if there's anybody around. Okay, this is Sylvia. Can you please call the ambulance service for me that this man is dying here? They should come and then pick him. But now when you call the ambulance, I'm supposed to give them the location. I'm calling from Regional Health Directorates. I'm in their conference hall. There is a situation on the ground. Somebody has fallen flat. What values are going to understand? Right. So we need your help as soon as possible. Then they'll come. The numbers are there. Project the numbers. Let's call them. People say that this numbers don't work. But they work. The video we watched, they call 911. I don't know why our short 3-digit numbers are not working. That they are giving us 10 digits. That my own number, times I forget it. I have to memorize. The 193. What is about the number? Is about to call the 193. It goes to Accra. They will respond in Accra and now transfer the call to the region where you are. And now the region will now receive the call and have conversation with you. Look at the so as we are here, we can begin to advocate for short, workable, digit contacts. Okay, something that everybody can recollect in the house. Because the MTN, those numbers, if you don't save them on your phone, you cannot call them. So you call. Or if there's nobody around, I have to call myself, then put the phone on loudspeaker on the floor while I do the CPR and keep on monitoring the phone. If they answer, then I tell them what is happening. They'll come over. Right. So the standard practice is that if I call you, I tell you to call for help. If there's another person around, I ask the person to bring the nearest AED, the nearest defibrillator around. US, UK, they have it all over. It is even recently that hospitals in Ghana are getting the AED. So our emergency system or emergency practice in the African continent is very bad. But we'll reach there. We have started. So yes, inshallah, we'll reach there. So you bring the AED while she calls for the what? The ambulance. Then how do you do the CPR? The midpoint, okay, of the sternum. So if this is your dominant hand, you are going to go this way and put this one on it, interlace, and then like this, you kneel down, okay? Straighten your, I'm going fast. Straighten your elbow joint, okay? Not like this, no, like this. Then you do the compression. 1, 2, 3, 4, 6. Then you come here, head tilt. Okay, head tilt, chin lift. You open. You pinch. Okay. Into the mask, out my mask. Then when you do that, you come up. 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Then right. That's the situation. So we keep on doing that. In the hospital setting, when the patient is already on mattress before getting the arrest, you cannot do the CPR on a soft mattress. You need the hard surface so that the pressure does not go into the mattress. Okay, if the mattress is soft, you have a spinal cord that you can put under the patient, or you have a CPR board just for the torso from the waist up of the patient. You put it under, or better still, move the patient to the floor. Then you do your CPR. Are we getting it? Are we okay?
Yes.
Who will come and demonstrate? It's hands on. That was it. Yes, it's hands on. CPR, yes.
When I get there,
Yes.
access to the area to see and if people are too close, I have to tell them to go back. Then I instruct one person to call the ambulance. Then the other person gets the ID.
The AED, you have it in mind, you have to call for AED. We don't have it here, but we call for it. Yes, that's a protocol, yes.
Then I get down and assess the patient. If the patient is breathing. And also check the chest compression if it's rising and falling.
So don't tell us let's do what you are supposed to do. So you come back and start all over. Because you have told us now you have called all those people before with assessment. If the area environment is safe, no danger to you and the victim. All right, we have checked the response. Patient is breathing. Patient is breathing, the response. Yes. The recovery. Yes. So let's lateral. Eye on the left or right. But have you seen that position? Okay, left lateral position. Normal for the recovery position is left lateral position. Yes, you lie like this. All right, for your patient, you after assessing the heartbeat and this is be there. What did she do right? What did she do wrong? It's okay. Then the patient back to supine position. Okay. What did she do right?
Well, she checked for the pulse and the circulation.
Okay.
But then she was supposed to ask questions to get response.
Yeah, of course she did right.
Oh, okay.
Okay. All right. So what didn't she do right? What did she do wrong? Yes, because if you have the response, you don't have to check the pulse and listen again because the patient is responsive. So come back again and go for the response. Right. Yes, the environment, the safe. Yes.
Hello.
Yes, sir, can you hear me? Are you all right? Is everything okay? No response. Yeah. No chest movements, no pulse. Carotid pulse is absent.
By the kids out.
All right, thank you. What did she do right? What did she do right? We all said here. What do we think she did to her? I do it. Yes.
She was studying as a mathematician. I think she did it hard. I don't know if it's really hard.
You are listening for response. So whichever way you do it to get the response from us.
So she was writing this thing hard.
Yeah, because at the hospital, you will apply pressure to the nerve right. You apply pressure to the nerve that you receive the response. And it's painful. Or you hold this transit, you are no longer doing this chest massage. So, we don't rub the chest again. So you apply the pen or pencil, any object to the event. Or you hold this massage. Is it like a patient? Stenomastoid. So this one there, you grab it and then you press it. It's really painful. If the one is responsive to pain, when you do it, the person will elicit movement, either withdrawing away or towards the pain. Right. So what else did you observe? I think one thing that she used to do was that she took the time to keep the end of the she did it. All right, since we are not mentioning the things she did well, what are the things that she didn't do well?
Oh.
Or what did she miss? Okay, ask the right.
And she also remembered to do the 30 to 20.
Okay. All right, then let's go to the bad things. Okay, the things she missed out.
Okay, so I noticed that after the first one, the subsequent ones were not rhythmic. It's like she was getting tired. So I done it very fast. I mean, I think there was one that didn't even get started. So yes.
Yes.
Okay, so I also observed that when she was in the preparation, there comes to street.
The elbow joints.
Okay.
Yes.
So that was my observation.
All right. Good. What else? Yes. I think the
Yes, bring the
the conversions. The whole hand was on the chest of the individual. All right. Yeah, so the police was supposed to raise was still on their chest for their. Those online, do you have any comments? You watched the second video. What did she do wrong?
She said there's no pulse, but she went ahead to do the CPR.
The slow pulse, give her the mic to read the comments. You can leave your comments in the chat box for us. We are looking at the steps she omitted. Did she call for help? You did? Yeah, good. I think generally you have you've done well, but the compression is the major aspect of the whole thing. Okay, because if you are able to compress and you do not provide oxygen to your done something. Remember the image we saw. The guy didn't compress; he only gave oxygen. And you know when you are electrocuted, the electricity, you know the joles you are subjected to only put your heartbeats into chaotic motion. Okay, so instead of you to have a lambda, you don't have the lambda again. You don't have the maybe you be having maybe fibrillation is quivering, it's twitching. The muscles are only twitching, they are not pumping. So the guy was only giving oxygen, but this guy survived it. So if you're able to give the chest compression alone, and you are scared of doing mouth to mouth, you don't have the mask, you need the chest compression. It can save life. And then your compressions, as someone mentioned, you were able to come this way, good, and then the weight is from your shoulder, okay? It's from your shoulder. So you need to be at the equidistance from the body of the hand. So straighten your elbow joint. I know it's not everybody who can straighten his or her elbow joint. Some people, no matter what you do, it will only be like this. So you come this way, okay? Then it is the heel of the palm, so like this. Okay? And then what I saw you doing, as somebody mentioned, your palm was like this, and you were doing this. Have you observed that? You were doing this. Okay, but the heel here, and then you go. Taking, you don't take your hand off the patient chest, but you allow for refilling of the heart chambers. Okay. Now, when you come here, you see this very well. When you do it well, you see the green portion of the red band coming out to tell you that you are doing it. There's not everyone who can compress for the green one to come out. So you push hard and fast. Okay, if I want to play the CPR. CPR. So you have to fall on this rhythm. It's regular. You are targeting 100 to 120 compressions in a minute. Okay, so if in a minute you are going to do 110 compressions, it's okay. Okay. That's it. Guys, smile. Okay. But no matter the situation, make sure we call for help and then start the CPR. Is understood?
Yeah.
But normally you should know how the protocol is. If you are doing it, you do maybe one cycle, 2, 2 to 3 rounds of the compression. You can check pulse. You can just check if the compression you have done has restored heartbeat. Okay, if heartbeat is restored, find out the patient is breathing. Two 2 years ago or so, we were getting close to the Christmas season. I was in the house with my wife in the evening time. Then we heard a shout. Because of where we were, the shout was echoing towards another side. And we're like, is it fire? Is it something that was happening in the house? And then we came out. Not knowing it was just behind where we were. We went there, this woman and the husband were returning from the farm. And then the man collapsed with the cutlass in the farm bag on the floor. And the woman was shouting. And then some women, okay, the people, the surrounding houses, they came out. There is a neighbor who is a soldier man. So when I called them, I assessed him. Then I called the ambulance. I told them that they should come. Executive died, when I passed the executive died, we are going to there is a in the bush. Then they should come there. The soldier man came down, he wanted to offer his salon car so that we sent him to the hospital. I said, oh, he cannot survive in the car. So the ambulance is coming. We should rather rush to the roadside and bring the ambulance men to the scene. So I started CPR. We are very religious. It's very good. Some women started and they were praying. So we were praying, and I was in the CPR. Some guys was okay. When I got tired, I told the guys to come, put your hand there, put this on it, and then sit. Did you see how I was doing? Say yes, you need to do it. And he was doing it. Oh, was that the man came. Was scared. I didn't do mouth to mouth, actually. Then we put him on the table position. I was monitoring, and then the pulse went off again. We brought him back to his back. Then we were doing the compression again until the ambulance came. When the ambulance came, they brought the AED, and it was a German. When I reported this, they nearly killed me. I didn't believe it. It was in German, so we're not actually getting what this was saying that. Put him to the ambulance, and then that's before we reached the city junction area where the road was very bad. And it is not good to even do CPR in transit on our bad roads. We were just going like that. Then blood started coming out. By the time we reached, we went off. But then the woman was, she appreciated what we did. The fact that the ambulance even came, because a lot of people were doubting. And the ambulance will never come. I said the ambulance will come. It will not come. But they, them, they will come around. And then another time I was, when I was saying something, it was late. And then I said, oh, let me go and cover my head. From Secretary Garden, those of you who know that road, Powerhouse Road, I took this area road and I think about 50 meters when this car didn't come from, bang! The car was overtaking us and hit the car. And the car went so, he threw us into the bush. And the car then, we were lucky that he didn't follow us. The guy didn't follow us into the bush. Otherwise, we come and just land on us over there. It was serious. Fortunately, those of us in the yellow, nothing happened to us. We were fine, but the driver, as to whether he was pretending, I couldn't tell. He was on the steering wheel like this. And I said, okay, they remove him. You want to put him to the car? I said, no, we are not going to do this. And I introduced myself. I'm a nurse. I work at an emergency. I am also part of I'm a victim. So we'll all be here. I'm not sure about my parents. I place the call to the ambulance. Are you sure the ambulance will come? This is why they can't going to take money. No one's going to take money. This service is free. They will not take money. It's an accident. Then they brought the man. I said the best we could do for him, put him in the vehicle. I assessed him. Pulse was present, was breathing. Maybe he went into a shock because of the event. So he's in the keke, and then I elevated the limbs to provide more blood supply to the brain. So it was there. The guys were actually angry. They wanted to take me by force. I told the guy that do not move here until I to him. We were there now, we came, the ambulance came, and then, but I didn't follow them. They took him away. Me, I went home and had a warm bath, took some chemo, and then slept. So that's it. Let's trust the ambulance, unless of course the ambulance is out of commission, the ambulance is indisposed, or the ambulance is not around. But if the whole central one is not around, they'll call the nearest ambulance. Petro is there, Adaplo is there, even Afajato South or Go West, they'll call them to come. So the best we could do for the victims is to do the CPR. Once the ambulance comes, then take over. That's person to demonstrate.
Okay, please, I have a couple of questions.
All right.
So we have Miss Na asking which hand is the dominant hand while doing the compression?
Yeah, everybody, mine will be different from yours, where your strength is. Okay, some people will put their where the power is. Am I right? T, right? I use right, but I observe that some procedures, my left hand is more powerful. Do you understand? So if it is your left hand that is powerful, is annoying you, you want to slap the person, which hand goes first? Is it your right or your left? That's the dominant hand. So if your left goes, okay, first, and then your right is here, I'm not comfortable with this one. Okay? I am not comfortable with this one. I'm not comfortable with this one. So when you come, you are not comfortable, you have to switch. Okay, so then I am right-handed person. So my right goes, then the left one is here. All right. This one is just providing the support part. The force is from here. Okay, then let's see. It might not be as effective as this one coming. Okay. So you can try it in the house, put your pillow down, and then do the CPR. Yes. Make sure your elbow joint are straightened. 230 compression. Everybody in the house should be able to know how to do the CPR on pillow. That's how we can learn to any other question.
Yes. Another one says, please, the 30-to-2 ratio, does it mean 30 compressions and 2 breaths into the victim?
Yes, please. Yes, 30 compressions and 2 breaths into the victims. Even at the hospital setup where we use bag and mask to a same thing, 30 compressions, then you press the elbow back 2 times. Back. And that time we are giving 100% oxygen. So your source of oxygen, we connect the elbow back to oxygen source so that the reservoir will be 100%. Then you'll be giving it.
Yes. The first one is about the chest area. Yes. See that soft because I'm pressing my what's okay or something. I mean, because the way we are doing it is
no, this is a timing design for CPR. So when you come here, there is a link here telling you where to put you can all come and see. And when you watch the map, you see this is how the human body is. Right. I earlier mentioned that it is the heart we are compressing, but does not mean that because the heart is located here, you have to come and put your hand here. when we are on the ward and we are doing compression, if the people are coming, those who have the training, you will go to tell. Those who don't have the training, to be able to them. Those who don't have the training, when they come, they just put it here, they are compressing. But lower half zone, midline of the what? Of the stem. So it's here. Can you see this in here? So it is one slide is like this, you are here. Let's go to here. This is for compression. Now, if you like, and then we compress your chest right now, we are going to distort your heartbeat. So we'll throw you into cardiac arrhythmia. Okay, so we either give you ventricular fibrillation or ventricular tachycardia, which will be pulse, there'll be pulse or there'll be no pulse. So if you want to kill somebody fast, you can give a blow to the chest. You just locate the heart and hit the heart. Trauma to the heart, most people die. Trauma to the chest, that's the heart. Anything to the heart can give cardiac tamponade, can let the heart bleed into the muscles, and then it will swell to be the fluid or blood in the cardiac muscle, giving the heart cardiac tamponade. The heart cannot be beating again.
Yes. One last question about you said we are not advised to use the mouse now. The mouse now,
God forbid if it's your child or
okay. So the mouth, there is a procedure in which
yeah, head tilts.
But I think when you're using the mask, this is how do you fix the mask to make sure that the mouth is open and then nose is free.
So when you're using the mask, you are not going to close the nose again.
But you open the mouth.
No, the mask is already covered. If you don't pinch the nose, the air will pass through the nostrils until go. You have to open the airway. Opening the airway, you know the junction, the larynx, and then the pharynx, that junction over there. You want to close the GIT and open the trachea, the pharynx. The pharynx leads to the GIT lungs, laryngoscopy. So the larynx leads to the trachea. And you want to open that junction. Okay. So when you blow it, to pass through the nostrils. If you do this, you open this. Okay. So if in the hospital, those people who are unconscious, so you see us putting something to the mouth, the oropharyngeal airways, like the TAG, that device, you put it into the mouth. It goes to sit at the base. The curved part goes to sit at the base of the tongue to prevent the tongue from falling back. Because if you don't put that, the tongue can fall back and block the airway. Then people who sleep and snore, that's what it means the airway is blocked. So the air passing through only have small space. It's like blowing the wind through a small pipe to make a sound.
Trumpet. So with the mask, when you are blowing the air, does it pass through both the nose and the mouth?
Yes. So this time the mouth is closed. I don't know how you can pretend that this is like
It's closed.
yes,
You blow the air.
so you pass through the nose. But because we hear both through the nose and then there is the mouth.
I also have a question. So how do you determine the area telling this whether it's oxygen like breathing? Do I just breathe in fully?
And then you breathe in, you kind of blow and then discharge. We have atmospheric oxygen that you take in. You take in, you hold it and give to the patient, to the victim. You don't make use of it. If you breathe in and then you make use of it, you are going to give more carbon dioxide than the oxygen. Surely, it is air that you are giving, which contains some amount of oxygen, about 21 or something in the atmospheric air. Yes.
What causes the little one away from is that very effective, like
Yeah, so the question is preventing direct contact of the lips to the victim's lip. So hanky to perforate it, then you use it.
so that's also effective.
It's also okay. While the secretions are coming, we wet the handkerchief but also benefits them from some. For the electrical problem of the heart, we have some medical conditions that can give you the electrical problem of the heart. And as I mentioned, trauma is one. Trauma to the chest can also throw you into cardiac dyspnea or cardiac arrhythmias. Okay. And then cause something junctional block. You know, when you look at the electrical conductivity of the heart, the SA node, where the whole thing starts from. SA node, then AV node, bundle, then the branches, then you go to the Purkinje fibers. Now the normal heart rate is 60 to 100, right? And if the person is not athletic and is doing less than 60 beats per minute of heart rate, then we are sure that the electrical generation of that person is not coming from the SA node. The SA node is supposed to give you from 100 to from 60 to 100. Now people come and their heart rate is 30 beats per minute, 40 beats per minute. It could be coming from the AV node, which is not the normal pathway of electrical conduction of the heart. It could be coming from the Purkinje fibers or the bundle of his or the branches. Are we getting it? So medical conditions can give you that, and the electrocution too can let you can disrupt the electrical pathway of the heart. Yes. And if someone has cardiac arrest and it is electrical issue, which is of course cardiac arrest is electrical issue, the defibrillator corrects it in time. And then when you defibrillate the person or shock the victim, it's not going to keep you sinus breathing immediately. You can move from ventricular fibrillation to supraventricular tachycardia. You can go to atrial fibrillation. You can go to bradycardia, and all these have processes or protocols on how to manage them. Okay, so if it is bradycardia, you are looking at you want to pace, introduce pacer, or you want to give the patient the atrophy, heart block patient. You give them pacer, either internal or external. So the defibrillators you have in the facilities, you can use them as AED mode, you can use them as monitor, you can use them as well as a pacer.
So for the first one, in the video watch, when the man arrives and how the season, I noticed the cards, they use the cards at specific places. So what are those places? Is it
Parts so this is left LN, kind of left lane, left the apex of the heart. Okay, so it's just at the apex of the heart. And then this one is RA. Okay, right arm, kind of just beneath the clavicle. Make sure that it is at the anatomical position. Yes. They are labeled. So when you pick it, LN, you can tell that. And the images are also from
For the second question, so at the beginning we established that cardiac arrest and heart attack and cardiac infection are two different things, and CPR is mainly for cardiac arrest, right? So what do you think when you notice it's not cardiac arrest but a heart attack? Is there any first aid we have for heart attack?
So I can lead you into cardiac arrest. Heart attack is when the muscle of the heart is not receiving blood. It's not receiving because it's not receiving blood. There is deficit oxygen supply and glucose to the muscles. Then you'll be feeling pain, chest pain. Now, if somebody says chest pain, you come to the emergency, say, "Oh, I'm feeling pain in my chest." The origin could be GIT or cardiac. So how do you differentiate between the GIT and the cardiac one? If you want to elicit for MI, myocardial infarction, the classical one is that chest pain radiating to the shoulder, through the left arm, to the jaw. Okay, to the jaw. Right. If the one doesn't come to the hospital early, or to follow suit is breathlessness, and then sweating. Dizziness comes in, by the time you realize the person goes off and can go into cardiac arrest. That is, the heart will stop pumping. Okay, so somebody can walk to you with heart attack. Okay, so the short distance is Mona. Somebody can with heart attack as emergency personnel. Mona, you have to give them medication, morphine, oxygen. Nitro, this name is always from this one. Nitro something glyceride. We have it sprayed to and give the one, or you give put another time. And then an aspirin. If you don't have aspirin, anything antiplatelets like Bupidogram, you can give the one. Okay, I've seen my first MI patients at emergency. The guy was just walking. That you are not fine. Say yes, my son. My chest is paining and he's sweating already. Oh, by the time you got to bed, he's unconscious. But luckily, there was pulse and then he was breathing, but just unconscious. Everything ran through the protocols. Then he was fine. But he died out of MI is complication of hypertension, long-standing hypertension, MI. Or if you have a clot stone into your ability, to your system, they can go and block the coronary artery that supplies blood to the heart muscles.
That's the reason when you notice it's not cardiac arrest, just rush the person to the hospital.
Yes, the patient is responsive, or if not responsive to the pulse. And if you can feel the pulse, you don't have to compress the chest. You can only compress the chest when there's no pulse. Are you getting it? So the question is that, can someone have absence of cardiac outputs and be breathing? Temporarily, when the process is ongoing. Because if the heart stops working, agonal breathing, for some time, then it will cease. Then if it ceases, no breathing distance, you only have a golden opportunity to do something to save. Remember, within 8 minutes, 8 to 10 minutes, there's biological death. 4 minutes, this one cannot maintain viability. So heart attack can lead you into cardiac arrest. Transform. Who is next? Okay. Ask your question.
Yeah. So that means we are not compressing until the breath retains. We are compressing until help comes. Okay, in the scenario you mentioned earlier on, you mentioned that the man came, but then you kept compressing. So question is, we are not compressing until the breath comes. We are compressing until help comes.
So when you are compressing and you realize that it is bad, if it gives that sign, then you have to check for pulse. There could be pulse, it's now breathing, but it's not fully because the oxygen is not sufficient. Right. But if there is cardiac activity, you don't have to compress the breathing in the chest. Are you okay?
Yes.
But if there's no cardiac activity, you have to be doing it until help comes. Or you stop when you are tired. You can't kill yourself.
Okay, please, you mentioned that to check the person's alertness, you do anything possible. So, I noticed that, and my brain knows, I think some people might do it in actual scenarios. The use of strong smelling, like some people use spray, some people use spirits. They bring it along the emotions of the person to bring them to consciousness. Is this advice?
It could be that the person has fallen, the person is breathing, but unconscious.
So if it's a cardiac arrest,
But I don't know why they'll be doing that anyway. If the person is asthmatic, then you introduce those consonants, you worsen the state of the one. Even pouring water on the victim is bad. Because in the edges, hypothermia is one that can give you cardiac arrest. The edges and then the edges and then the T's. They are now 12, about 7 edges and then T's and then 5 edges. Hypoxia, hyperkalemia, that is high potassium in the blood, hypokalemia, that is low potassium in the blood, hypoglycemia, the hypothermia. That's fine. Then the T's, toxins, that's sepsis, cardiac tamponade, tension pneumothorax. Which one again? The trauma will give you a tension pneumothorax and then the cardiac tamponade. So it's for those things I mentioned. So if the victim comes to the hospital, these are the things that we quickly do. So in checking so if the person comes, the first thing that we can quickly resolve is hypoglycemia. So if it is the hypo, people come with 1.2, 1.1, 1 hypoglycemia, glucose level. It enters 0. So when you do the 50, it takes some time, then they are back to life. Then why did you bring me here? What's happening? Then you get to ask you those questions. What am I doing here? You're going to ask you those questions. Hypoglycemia is one of the finest things that people manage, but it's a bit complicated too. So if somebody is responsive, you are lying down, I think to tap you, respond. The person then will be lethargic. So respond to you, then go back. When you tap again, open the eyes, answer the question, then go back. Are you diabetic? Are you taking your medication? Are you eating today? No. That's okay. Fine. We find something for the person to take. The person can swallow. But the key is to move quickly to the hospital. Yes. So the next person for the compression. 1 man.
Please, we get the suggestion here.
All right.
I think one of the guys will volunteer.
Yes. Okay. No, that's cool. The scene is safe. Okay. The scene is safe. Yes. So the person is lying there, unresponsive, no movement. Yeah, the man did not answer. The man is unresponsive. Force is yeah, okay. If you don't have anything to do again, you CPR, just compression. You have called for the AD. So who is sending the AD? Yeah. So Sylvia, okay, Sylvia. You can start the chest compression. The AD will come. The one is going to pick the AD for you.
Thank you.
1, 2. So 10 compressions to 2.
I think the box is
No, what's not a CPR? On the beats you have here, just compression on the beats you have here. Push hard and fast. You are behind this. You are behind this guy. You are behind the baby. The AD is there 10 minutes or 20 minutes, not applied yet. It's not going to stop for you to apply the AD. Minimal interruption. 10 is the other hand. There are 2 pieces over there. Okay. Continue the CPR. Actually, it has to locate where to put the president, the parts. Because time is of essence. Just show us how you apply the parts. The apex of the heart, and then the heart in. Good. So ideally, you can time him at the point where you want to administer the oxygen, then you quickly apply your parts, then you give way. So when you apply the parts, what happens? So you apply the parts and switch on the AED. Yes. So it's asking you to check the parts, of course, because it's not a live body. Even if we remove the covering and we apply it, it's not going to be sensitive. So we just leave it over the parts. When you apply the parts, you stop the CPR, you stop the chest compression. For the defibrillator to analyze the victim's heart and see if there is any activity at all, because there could be cardiac activity which is not pumping, okay? There could be fibrillating. It's twitching, that is ventricular fibrillation, but the heart will not be injecting blood, pumping. And when the machine gets that, it will analyze, ask you to clear. Nobody should touch the patient, because if you touch the patient and you deliver shock, you will slow the system. And so if it is the manual one, you give the instruction. Okay, after applying the manual one, you apply gel to those 2 points where you are going to apply the parts. So you apply the gel there, and then you give the instruction. I am clear. Everybody clear. Then you have the response clear. Nobody should touch patient. Then you deliver the shock. After delivering the shock, you continue the CPR, the chest compression. So with this one, because this one is automated, it will only ask you to shock or tell you shock not advised. If it says shock not advised, it could be that the patient has return of circulation, cardiac activity. It means that it's pulse. The patient will be breathing at that moment. So you position the patient at a recovery position, left lateral position. Because if our setting here we don't even have the AED, so it means the ambulance will carry the guy to the hospital. Yes. I think he has done with this, the fact that he wasn't there. So the essence of the whole thing is ability to compress the chest and administer oxygen. Compress and administer oxygen. That's all. Any other person? Can we have, or you have another question? Yes. Yes, when you do that, remember the book is secretion saliva in the mouth. At this position, it will just come out. We don't have equipment to be doing suction pre-hospital. And then when you do this one, you open the airway. Have you tried to lie like this in bed in the house? Try and see when you are in that position, you sleep very well. Left lateral position. You sleep very well.
Oh, my phone is big.
Because if the one is like this, the tank can fall back. If there are any separations, if the one doesn't have that influence, and enter the airway and have aspiration, then we come to the hospital with aspiration pneumonitis. Yes, boss.
So, during the chest, right? So during the chest conversion, I want to ask, we the chest down, when they lose.
Can we watch the video again? Yeah, during chest compression is allowed to break ribs. If you break the ribs, and the ones survive, the ribs will heal. The bones will heal. It's better than not breaking ribs for the one to die. So for elderly people, osteoporosis, most of them when you are doing, you feel it. Then you see the chest sagging. The chest will sag. Now you sit down. And we continue to do it.
So yes, the follow-up question is that's in the for all age groups or yes adults.
No, it's for all age groups. Maybe go to the YouTube and enter CPR for pediatric babies. For babies, neonates, maybe less than 1 year. Okay.
It's said for
pediatric CPR. Now, you can choke. Babies can choke. Okay. If they choke, coffee or adults can choke. So how do you there's international or universal sign for choking? So hold this the neck like this. If the person can breathe, you encourage the one to breathe to cough out. If the person is the one can cough out. So in coughing, maybe it's chicken thigh, the person is like this or bone, it's in the airway, can cough it out. Okay, so encourage the one to cough. I'll come back to the question. Encourage the person to cough out. But if the one is coughing, it's not coming out this time. So this is also part of basic life support. So you can go to the back of the person with this arm, form a fist, put this one here. Okay. So you do abdominal thrust. Okay, you push hard and upwards. Push in upwards. So when you do this, you increase the pressure in the abdomen. Then what is in the throat will come out, will follow. But if it is babies, maybe playing babies like those crawling peanuts, corn, beans, then they swallow and then they are coughing. You pick them up like this. Then you give them 5 slaps at their back. Okay. Okay, like this.
Summertime, children and families are out playing, especially in the water.
Then you train them. You check them out. You open the mouth to see if the object is dislodged into the mouth. If it is dislodged, you pick it. Now, if it's in the house, you don't have the first step to pick it. My key first. So carefully open the mouth, insert your fingers and pick them out. You don't do blind sweep. Put one finger in the mouth to sweep to see if you can get the object. You can push it back. Okay, like that. So you can see object is not there. Go back like that. Okay. If it is a toddler, you can kneel down, have him, then do the listen for him. If there's nobody in the house to, you can have a chair yourself. Eating the rice or the chicken, and then you get choked. You can bend over the chair, then you go over it like this. You know, this side will apply the pressure here, then can help you discharge whatever you have. Now for pediatric CPR, babies becoming unconscious. So babies, they are very small, so you can just hold them like this. Okay, they can be on the bed like this with your thumb, one on this, one thumb on the other one on it like this. Now you do 15. For babies, it's 15 is to 2, not 30. Okay, so you do 1, 2, 3, 4. Okay. You can actually hold them like this, babies, and then you do twice. It's like this. You compress it. For toddlers, school going age, about 6 years, 7 years, 10 years, you use only one and 2. Also, 15 is only one, because their chest is very fragile and it's not large as adults one. So you can just be it in the house or this. So that's the CPR steps, check for responsiveness. Is that baby pediatric?
Yes.
So we're still going to checking for responsiveness or for help. It doesn't matter where it is. So even if it's in the hospital, you say that the patient is no more breathing, there's no pulse, you call for help. So emergency, we shout for code. There is code. You can mention where the code is. In cubicle 1 or cubicle 2, everybody will run and bring their things for the resuscitation. So checking for breathing and then watching the chest as well for rise and fall of the chest. So we call this one rescue breath. Before we start the CPR for pediatric, you give 2 rescue breaths. You see the chest moving. This one too, if you put your mouth on it to do it, the chest will rise like that. So you check for pulse. Listen, which year is this one? Because there have been updates on the things, so there are some things that we are not doing.
Hopefully, like 4 years ago.
So
there's 2 years on here.
2 years old over there. That's 2021. Okay, I think it's current. I was CPR for babies. Okay. You can have a full screen. And then here, online phone. But the sound is not.
Because we are projecting, we need an external speaker for that.
Okay. I have one speaker inside of this. One small speaker. Bluetooth. So if the baby is conscious, no CPR. This baby is black. So head tilt, chin lift for babies too. So unconscious baby, absent breathing, and then pause. The chin is very small, so you can't put 2 fingers there. So you can use that as a finger to elicit the chin lift. So the surface should be hard, not bouncing. Then we'll get a good chest compression. If the baby is bouncing, the surface is bouncing. So 2 fingers for this kind of babies. If it's tiny, big there. Can do the down 1, 2, 3, 4, 5. The fact that it's a baby or child does not mean that he or she cannot benefit from a defibrillator. Whatever applies to the adults applies to children, but in reduced quantity. See their parts very small. You see where the arrow is. This one is not labeled like this, but the arrow is pointing, showing you where you are supposed to apply it. If this one is applied to the back, purpose will be achieved. So not to touch patient, play, analyzing the heart rate, shock advice, charging. So when the shock is advised, it will charge first. If it is a manual defibrillator, you have to charge before you deliver the shock. So it's charging. Press that one to deliver the shock. Continue CPR. So for babies, danger, check environment for danger. Dr. What? Doctors ABCD. It is the old version. Because for chest compression, we are not the most important thing is to send blood. So I was telling you it's CAB, not the ABCD way. So some of these versions have been updated. Every year, the American Heart Association updates their protocol, their guidelines. No, it's after every 5 years, but I think since 2020 or 2021, they said they'll be doing it yearly, no more after every 5 years. So they go, and then at times they go and then they only add. So when you look at the chain of survival, it used to be 5. It used to be 4, 5, and then 6. Now it is 6. They've added post rest care and then recovery. Because what happens is that even on the ward, after the advanced cardiac life support and the patient is back to life, everybody is happy. Then we quickly forget that this patient can go back to arrest again. So now post-arrest care is in the guideline for you to know that this patient can go back into arrest. So somebody should be dedicated. So this patient can be sent to ICU where they do 1:1 patient or 1:2, 1:2 patient. Not like the ER, our patient, 1:8 patients per shift. It's very bad. Please. So do you have any question again? I think hands on. Who will come? The compression is very important. As you are observing, you think you can do it. Those of you online, if you are in the house, you are in the workplace, and you think you have something that you can compress, if you have a pillow, just put a pillow on the floor or on the table, and then let's have just on your video, let's see you perform the CPR. Is anyone of you want to try? The compression, when you are watching it, you think, oh, you can do it until you come to the dummy. So who will come? Another person should come so that we see. Thank you. Barbara. Sister Barbara. Yes. So you are the units, you are your units, then you have a client who is coming for advice on, you should see it's a non-diabetic and then a long-standing hypertension has been coming to the facility. It has a previous history of myocardial infarction. And the previous slide will be experienced some slides chest pain before coming to you for advice, dietary management advice. So he entered your consulting room and then he started experiencing the chest pain again. I was telling that my chest is hurting. And by the time you realize it's on the floor, what will you do? So he's the one here on the floor. His name is Mr. KB. So this one is happening in the hospital, but in your unit. Understood? So what will you do?
That's my power.
Okay.
Thank you.
There is no response. If the lady was talking between a few minutes, just collapse and no response to your query. There's no chest movement. There's no pulse, no carotid pulse. They are calling the emergency nurses, the emergency ward, no one is answering the call. The one we sent for the AED is looking for the AED. I think there's no AED in the unit, so it's gone to the CT scan unit to see if there's AED over there, which is close to your unit. There's no AED there too, so it's run to the psychiatry ward to say the psychological medicine. department to see if I get one. Okay, he has gotten one now. Then call to the emergency unit, they have responded that they are busy, so you should find a way to bring the patient to the unit. Effects of the heart, the LM. That's the fifth, fourth to fifth intercostal space. Anterior axillary line. Change it. At least let's say you open the way, change it. If you don't change it, you are not open the airway for what you are pushing in to go through. Okay, analyzing. Shock advice. Charging. Plan. Okay, shock. We press the shock one. Okay, consider CPR. She said you should call the emergency unit. What are the emergency nurses coming to do? Doctors coming to pay your unit. Find a way to send the patient to them, not then they coming to do. Yes. Because you could just imagine when the unit is, when the emergency is, but you can buy time by doing the chest compression. Okay? Doing the chest compression while you look for a vehicle. Now we don't have any ambulance in the yard. We are supposed to have business, we have the death station in the yard, but now we moved out. So when it's something like that, you control the CPR. Or somebody run to get a stretcher. Look at the scenario. Somebody goes to find a stretcher, you put the patient on, and then rush the patient to the emergency unit. When you do this one for some time before you bring the patient, it's better than not starting anything at all before bringing the patient. There are times where this incident happened at the X-ray room, and then they will run and come and be calling us. We will start something. As for the X-rays, that's the when they start something, they come to call, you can go there with the AED. While they bring the stretcher, and quickly they take down. This thing will happen at the banking or anywhere there. You have to start something while the ambulance comes. It will happen at the OPD. A lot of people in the yard have fight training, but when this thing happens, they are unable to act. Now is the confidence level. You have to be confident, be sure of yourself that you can do it. So doing something is better than doing nothing at all. So we have to try and do something for the victims. If it is electrical issue and if the data is on, it will detect it, correct it. It will pass through several arrhythmics, but eventually you may have a sinus bleeding. A life is saved. It's better than not doing it at all for the patient. Yes. Somebody wants to try it. I'll give another scenario. All right, we assume we can all compress. If there's no compressor, I want to thank you for your attention. Those online, thank you for being with us. How many people do you have online now?
We
How
had
did you start with?
We started with 38.
Okay. Thank you for your attention. I also thank you, those of you present here, for giving me your ear. So BLS, all that we were talking from the beginning is that early recognition of the event and timely intervention, as well as a trained personnel on the victim, is key to the survival of this victim. Thank you very much.
Oh.
Thank you very much, Mr. Chief. Please, are we tired? The morale is going down. Okay, so yes, like we preach and as usual, sitting for long hours, need to get up and stretch your body a little. So if we could all be on our feet and shake off the stress from sitting. Okay, so our things are preparations also going on well and the bad day for our snack, our healthy snack. Okay, all right, please let's stretch. Who wants to take us to a short stretching session?
Hey.
Ima.
Why, Ima?
My volunteer, help me take us to a short stretching session. Okay, so we are following your cue. Yes. Body, what?
I think you this way. So please let's go this way. Let's go the other side. Then let's go this.
now.
Let's do this one.
Get out.
So let's go back and forth. Okay, thank you.
Welcome.
Thank you very much. Yeah, so, most of our questions regarding the, CPR training has been answered. We want to say a very big thank you to Mr. Chief for availing himself and taking us through this very, important training session. And this is, we are lucky that we're able to have access to this. I mean, you go through 4 years of training and then we never had a session on CPR training. And also this is a great opportunity for us to have links. And we are very grateful. So we have snacking as our next session on the program. But while it's getting ready, we want to start talking about our incoming conference. Please, do we have